can see Richard, and I think we're beginning with you, Richard. So over to you.
Thank you so much, Ellen. Can you hear me okay? Fantastic. Thank you for the very kind invitation to be with you all today. Irene and I are delighted to be joining you. So our Centre for Global Health Palliative Care has been active in Sub-Saharan Africa for the last 20 years, and indeed South Africa was our first focus country, and we are still working there fairly intensively now. And of course, Archbishop Tutu was a strong advocate of palliative care. And indeed, we were delighted many years ago to join the King's delegation to his birthday party hosted by Kings at the residence of the British ambassador in Cape Town. And we did a number of visits with home palliative care teams from South Africa with the senior King's leadership team, which was really illuminating for them, I think. So I will share my slides with you now. I'm hoping that you can see them now. Is that okay? Okay, I'm presuming that you can see this. So thank you very much. So I'm joining you from the Cicely Saunders Institute. As said, we're introduced. I'm director of the Institute, and Irene Higginson, who is our faculty dean, will be speaking after me. So Archbishop Tutu was a very strong palliative care advocate within South Africa and beyond. And he made a really, really powerful statement that dying is part of life. We have to die. And since dying is part of life, talking about it shouldn't be taboo. People should die a decent death. For me, that means having had the conversations with those I've crossed in life and being at peace. It means being able to say goodbye to loved ones, if possible, at home. So this really echoes all that we aspire to do at the Cicely Saunders Institute at King's, and particularly from our Global Health Centre, making sure people all around the world have a decent death, and where possible, if they want to, enabling people to die at home. So it's great to have the Archbishop speaking so powerfully on this topic. So in terms of the evidence, why should this matter quite so much? Why do we think about global health palliative care? So what you have in front of you is some data we published in Lancet Global Health a couple of years ago, using the WHO mortality data to try and estimate how many people spend the last year of their life with suffering. So we can see that from 2016 to 2060, in the yellowish bar, low-income countries, we've got from around 2 million up to over 5 million people dying each year with suffering. And in lower middle-income countries, 9, almost doubling to 16, nearly 17 million people dying with serious health-related suffering. So that is serious physical or psychological distress. And that's what palliative care was developed by Dame Cicely Saunders to manage that distress associated with end of life. And the way we do that is by being person-centered. Now, much of what we've done in South Africa and across sub-Saharan Africa has been in the context of HIV, although we also work in pediatrics, in cancer, multimorbidity, aging, primary care, across the continent. But I'd really like to quote my colleague Carla Alexander from the Institute of Human Virology, who talks about person-centered care, moving us from the life of the virus, the HIV virus, to the life of the host. And palliative care, as developed conceptually by Dame Cicely Saunders, who again trained at Guy's Hospital and St Thomas's Hospital, and you will have seen her picture, some of you, on the Strand campus outside, where we have King's World leaders shown from throughout history. She really helped us think about the idea of total pain. So a person-centered approach is taking in physical problems, so like pain, other symptoms, social problems, emotional problems, and spiritual problems. And understanding people's spiritual distress and managing that at the end of life is absolutely central to what we do. So when we've conducted research, yes.
Sorry, Richard, your slides aren't moving forward. I don't know if you're
not. Gosh, that happens sometimes, doesn't it? So let me stop sharing and then reshare. Thank you for alerting me to that. Okay. All right, let me just restart those. Thank you for that. I'm just going to restart my slides and hopefully that will work. Okay. Thank you for your patience. Okay, so if I share this now. Now, did you see this slide okay? I don't know if you can hear me okay.
Yes, we can hear you and we can see that first slide.
Okay, so that was the slide, the nice quote about palliative care. Now, can you see this data from Lancet Global Health?
No, we can only see the opening slide, Archbishop Tutu's advocacy.
Oh dear, okay. I'm not sure what's happening here. Does anybody with tech expertise want to give some advice here? I'm not sure. Apart from closing them and reopening them, I'm not sure what else to do.
There we are. Now we can see a data slide, future projections of need.
So that's the projection. So this is showing us then that 17 million people are going to experience serious health-related suffering in the last year of life by 2060. So it's very, very important that we focus on addressing that now. Can you see this person-centered care slide?
No, we're still on the future projections.
Okay.
Yes, now we can.
Now you can, great. So person-centered care is really important in terms of taking account of people's spiritual care needs. Has that moved on for you? Importance of spiritual well-being?
I think there's just a delay between your moving them on and us seeing them. It's still person-centered care.
Okay, and my apologies for this. So if you could let me know, just give me a quick nod when the slide moves on, just so I know where you are, that would be great. So we have conducted primary research in sub-Saharan Africa with people in the last year of life to understand the importance of spiritual well-being. So we recruited 285 people, majority of whom were in South Africa, but also in Uganda. Also, the majority of whom who had HIV, about a fifth of them had cancer. And what was very interesting is we got them to complete a quality of life measure. And what they do within that is weight what's most important to them. And what was very interesting in the African sample is that spiritual well-being was weighted by patients at the end of life more heavily than anything else. So being at peace, having a sense of meaning, were weighted as more important to patients than being active and physical comfort, which is very, very interesting. So if we really are going to address what matters to people at the end of life, then we have to be person-centered and multidimensional. Otherwise, we're not addressing the things that are most important. And also, of all the domains, yes.
Sorry, could I just interrupt to say the slides aren't moving forward, but we have a suggestion in chat that if you stay in the editor mode, the slides will move on our screens as well as yours.
Excellent idea. Yeah. So let me just close that. Okay, I'm going to share again. Apologies for this. Right, is that working?
Yes, I think so. Brilliant. Yes, those are moving forward.
Fantastic. So the important message from this slide is spiritual well-being is more important to patients at the end of life than anything else. And it's the strongest correlation to overall quality of life. So when somebody at the end of life ranks their quality of life, it's spiritual well-being that correlates most strongly to that overall concept of quality of life. So spiritual well-being is very, very important. And then when we ask 72 patients to do cognitive interviews, so ask people to tell us what something means as they measure it, and got them to describe what being at peace meant, it had a really nice broad sense of spiritual well-being. So perception of the self and the world, relationship to others, and spiritual beliefs. Because, of course, when you're measuring spiritual well-being, you want to include all religions and none. So for people who have religiosity and those that don't, because spiritual well-being, of course, is a very broad concept. And we've been able to measure that with this item of being at peace. So very interestingly, a PhD student who's with us at the moment from Nigeria, Dayo Afolabi, has just published a systematic review of what matters to people with serious illness facing the end of life across Africa. And he's systematically reviewed all of the available studies. And that green bar on the left is the number of primary studies reporting on different domains of need. Now, I've already shown you that spiritual well-being is the most important thing to people at the end of life. But you can see, compared to physical well-being, psychological, social, information and financial concerns, there have been fewest number of studies on spiritual well-being. So it matters the most, but we study it the least. So there's something very, very important in there, particularly when what we can see from the available evidence is that the rights which are associated with cultural and religious beliefs at the end of life are very, very important to people. So what that's enabled us to do is to really develop a program of person-centered measurement across sub-Saharan Africa with all of our partners. So first of all, the paper on the right was a systematic review in the Lancet of what we know about palliative care in sub-Saharan Africa. Then a survey of providers with the US government finding out what should we be researching, which said we need to be able to measure outcomes for patients and do person-centered assessment. Then we consulted with multi-professional practitioners across Africa saying, what should that measure do? What should it look like? Then we developed the measure and started piloting it in 5 countries and then validated it finally in South Africa and Uganda in amongst about 800 patients. So where we are now is that the Hospice Palliative Care Association of South Africa and the Pan-African Palliative Care Association advocate our measure as the standard measure to be used across sub-Saharan Africa to measure palliative care. And what people in the field have told us is that it was difficult to measure quality of care and patient-reported outcomes until we had this culturally appropriate measure for palliative care. Very briefly, I wanted to touch on this. One of the great things that Tutu did was talk out on LGBT rights in South Africa. Some of you may remember his fantastic speech about all people being welcome in his church community. So we've been working with a number of colleagues in Zimbabwe, funded by the Open Society Foundations, to understand the experience of LGBTI people and sex workers in their experiences of accessing healthcare. You can see some very challenging quotes there before you. I won't read them out, but I think they speak for themselves. So his work on human rights and palliative care have come together really strongly under his umbrella of equality and his focus on LGBT people. And again, with sex workers, we can see in this studies that we published with our Zimbabwean colleagues, there are also exclusion from care for people according to the kind of the moral code of the healthcare providers within the clinical facility. So that work has really resonated in our African palliative care work. And I'd just like to end on this slide. I prepared for my death and made it clear that I do not wish to be kept alive at all costs. By Tutu, who was a founding patron of the Hospice Palliative Care Association of South Africa, who've been our long-time research and implementation partners. So thank you very much, everybody, and I'll hand over to Professor Higginson.
Hello, Richard, and hope you can hear me and see me. Is that possible?
We can. Yep.
Excellent, fantastic. And I'm going to try and share my screen as well. And just in a way, this follows on very nicely because we did, in many ways, the south-north activity in palliative care, taking what had been learnt in Africa to the UK. So I'm going to try and share now. Can you see that all right? And then let me put it on screen show if that's possible. Is that possible for people?
We see your slides, Irene.
Great. Okay, fantastic. Then we'll keep moving through, I think. There we go. So modern palliative care is the sort of care, as Richard's highlighted, that puts the person and those important to them before their disease. And certainly in many parts of the world, this is now being increasingly recognised. And it's really taking the idea of enabling people to live up until the time they do, but not necessarily prolonging life. It's aiming to add quality to the remaining life. There's no evidence that it shortens life expectancy, but the idea is not about life expectancy. The idea is about quality of life. And Cicely Saunders was one of the first people to bring in the idea of spirituality in palliative care with her image of the body and the mind. And you can see by many of the terms in this image here about the fear.
Irene, we're not moving on.
Oh dear.
Irene, this is the same problem we had with Richard's. What's happening is you're sharing the screen where the original PowerPoint is, not the presentation. If you take it out of presenter mode, then we can see the presentation.
Hang on, let me try again then. Thank you so much, and sorry about that. I can see today there's been a few glitches. Can you see it now?
That's your first slide.
See it, yeah.
And it's not in presenter mode. It is in presenter mode.
It's not.
Now the slides aren't moving again.
Well, I'm not trying to move them at the moment, but let me see if I can get them back moving. So I'll try then. Is that moving?
No, we're seeing your original PowerPoint, not the slideshow.
Okay, all right. This is well, and never mind. I will try and work around. So let me try another way.
It's the window that's being shared is the issue.
Yeah, I think you're right. And so I'm unsharing, and I'm going to try and share a different window. Thank you for telling me. I'll be very quick in trying to get that. So share.
Thank you, Yannicka, for helping us in the chat.
How's that?
Okay, try moving it forward and back, and let's see what happens. Yay, that's looking great. Thank you very much.
Thank you very much. I've learnt something. So Cicely Saunders had this idea of the body and the mind, as I outlined, and hopefully you can just see that slide there with all of the images that she came up with. Richard highlighted the international need for growing palliative care, but this rolls across all of Europe. So you can see here the projected increase in annual number of deaths, which is the orange line, going forward up to 2040, and the palliative care need modelled on top of that, and therefore the effect on where people are cared for. And this means that we will need to increase community capacity, and layered on top of this, of course, is the increased diversity of our populations. And palliative care is important to many aspects of care, as you know. It's not just what's done in hospices, but there are palliative care units with beds, but there are also much more hospital palliative care teams, home palliative care teams, and home nursing, providing the different sorts of care. So let's come on to the spiritual aspects of palliative care. So much of the work in the UK was pioneered by Reverend Peter Speck, who was also a trained therapist, who worked with us and others, particularly out of the Royal Free, looking at, first of all, tools, then with Richard Harding and Lucy Selman on the needs of people with heart failure, and also with some of our students on the issues related to spiritual beliefs. And this work showed the body of need that existed. With building on Richard's work, we then began some South-North learning into spiritual well-being, and in particular, the components of measurement that came out of this. For example, the idea of feeling at peace and having a sense of meaning, and have you been able to get peace? And those terms actually transferred into the UK government's core outcome measurements, and then on from this into clinical guidance for migrant populations. So, for example, we published guidance building on the African guidance that Richard mentioned, which Desmond Archbishop Tutu was involved in, and very kindly wrote a foreword for. about living with incurable disease, such as those cancers, these are the words from his foreword, have the experience of illness that can have a profound effect on somebody's spiritual well-being, leading at times to crisis as well as opportunity to growth. And he quotes here Cicely Saunders' image of total care, the figure that I showed you earlier for patients and families. And so in these publications, we were able to take that forward. And the guidance is available on the King's websites still. It's shown here with the authors of that work, and his rest of the foreword talks about the specific recommendations that came out of those forwards, which looked at not only, because they were evidence-based, not only what the needs were, but also what could be done to develop more culturally sensitive services to meet people's spiritual needs. And particularly the action that was required from both palliative care services and communities at a grassroots level. And then finally, I just wanted to pay tribute really to Archbishop Tutu in his work as well and support of nursing. So here he is meeting nursing and midwifery students for a tea at the service in Westminster Abbey to celebrate the life and work of Florence Nightingale in the centennial year of her death. He says specifically, as a King's man, I'm thrilled to be part of the school that she opened in St Thomas's, and now he is an alma mater of the Florence Nightingale School, as it was then, faculty as it is now, of nursing and midwifery. And our link to palliative care was almost a related part of this. And I particularly like this quote from him of how she bucked the system that expected a life of inactivity. And she followed what she considered to be her divine calling as a nurse and a pioneer. And then finally, I just wanted to say thank you to the many colleagues who've contributed to all of this work, particularly Archbishop Tutu himself, but also Lucy Selman, who did her PhD in this area, and you can see her there wearing one of the newly designed Vivienne Westwood King's gowns. Also on the top left, Reverend Peter Speck when he got his degree, and then some of my colleagues from the Cicely Saunders Institute who were involved in this work. So thank you very much indeed for that, and I'll try and stop sharing, which hopefully I have done.
Thank you both, Irene and Richard. You've not only given us an insight into a little known area of Tutu's interest and work, but you have also given us back 5 minutes of our time for our lunch breaks, for which everyone will be very grateful. It's been a wonderful